Good morning, and thank you to the Florida chapter of the ACP for allowing me to present this interesting case. My name is Catherine Garrido. I am an OMS2 at Burrell College of Osteopathic Medicine in Melbourne, Florida. I'm presenting to you today a thought-provoking case that explores the progression of an infection that spread from bacteremia to infectious endocarditis from a well-established etiology in a patient with pre-existing comorbidities and a chronic severe hematological disorder. Infectious endocarditis remains a high morbidity condition requiring prompt recognition and targeted antimicrobial therapy. Odontogenic sources such as Viridans group streptococci are well-established etiologies. This case involves a 38-year-old female with chronic, severe, idiopathic thrombocytopenia purpura who relies on a Mediport for ongoing IVIG and end plate therapy. Her comorbid heart failure and the presence of an AICD further increased her susceptibility to device-related infection and subsequent vegetation. She initially presented with gingival bleeding, an expected manifestation and common symptom of her chronic severe thrombocytopenia. However, subsequent evaluation revealed a polymicrobial odontogenic bacteremia that progressed to endocarditis involving both her AICD lead and Mediport. I'll now turn your attention to the clinical course table. On day 1, the patient presented with the primary complaint of bleeding gums. Microbiology cultures confirmed Streptococcus gordoni and Streptococcus vestibularis with over 100,000 CFUs on blood culture. On Figure 1 under pertinent findings, you can appreciate Streptococcus gordoni growth on blood agar. On day 2, the patient was recommended for a TTE for possible valve vegetation. The TTE was performed and showed the right atrium with significant vegetations noted on the AICD wire and port. On Figure 3, under pertinent findings, you can appreciate the TEE with vegetation on the right AICD, as pointed by the arrow. On Figure 5, you can also see a diagram of how bacterial vegetations grow on an AICD lead. The next imaging that was ordered was a maxillofacial CT that showed scattered dental caries in the maxillary dentition, particularly tooth 9 and 10. To review the dental anatomy, you can appreciate the location of tooth 9 and 10 in Figure 4. And to review and appreciate the scattered dental caries in the maxillary dentition, you can review Figure 2. On days 3 to 14, there were several interventions that were made. Subsequent imaging with a TEE further evaluated the mitral valve and confirmed vegetations. The patient was also treated with IV cefepime 2 grams for 12 days, as well as end plate for low platelets, and started on IVIG 1 gram per kilogram twice daily for hematological management. On day 13, there was a repeat TEE that showed no vegetation. On day 14, the infection resolved, with white blood cells returning to normal levels, and after completion of her IV antibiotics, the patient will remain on chronic suppressive antibiotic therapy with Augmentin for the rest of her life. Of note, a repeat TTE was performed as a follow-up on October 2nd, which was normal without vegetative growth. To conclude, this case underscores the complex interplay between chronic hematologic disease and susceptibility to invasive infection. The patient's history of severe ITP precluded routine dental intervention due to her high risk of bleeding, allowing progressive dental decay to advance unchecked. This resulted, of course, into bacteremia, culminating in significant vegetation growths and endocarditis. The patient will need dental extractions to prevent this from occurring and lifelong augmented treatment, as mentioned earlier. Understanding how to manage an infectious bacteremia in an immunocompromised patient with active ITP exposes how complex infectious disease is and how it manifests. Counseling patients regarding this close relationship between oral and cardiac health, especially those with underlying disease, is paramount to prevent infection and consequential endocarditis. Thank you very much for your time and attention, and thank you again to the ACP and to my mentor, Dr. Newmarch.